And this is the mid-morning or late morning session, which is the panel. First of all, a big thank you to Jameel Institute colleagues, Neil, Katrina, Tim, Sarah, and the rest of the team for this wonderful symposium so far. I'm George Richards. I'm the director of Community Jameel and a long-standing supporter of the Jameel Institute. And it was great, I think, for me personally and for the rest of the team who are here to hear OJ and Bhargavi's presentation this morning, especially about the GI Rise project, which we're very honored to be supporting. It's incredibly important work. And on that same theme, we are now moving into our panel, which is titled Healthcare Interrupted, How Health Systems Can Adapt to and Recover from Emergencies. And this very much picks up on several of the themes that we've had this morning. I'll start with introducing the panelists. To my, let's get the order, to my immediate left is Olivier Le Polain, Unit Head, Acute Events Analytics at the World Health Organization Emergencies Program. He was previously Deputy Director of Operations and Senior Epidemiologist on the UK Public Health Rapid Support Team and has a wide range of research areas in surveillance, public health information, and beyond. Next is Marine Vignon from ALIMA, the Alliance for International Medical Action, based in Geneva, and Director of European Partnerships for ALIMA, expert on difficult-to-reach areas and resource-restricted communities in the humanitarian medicine space. Next is Sean, who I do know, but I'm just going to make sure I don't make a mistake. Sean White, Director of the UK Humanitarian Innovation Hub, 15 years experience in research, innovation, program design, WASH, infectious disease control, nutrition, and beyond. And we're looking forward to Sean's contribution today. And at the end of the row of chairs, Oksana Lovochkina, CEO of the Ukrainian Medical Charity, which is dedicated to advancing medical education and the healthcare sector in Ukraine in response to the Russian invasion. And joining us online, and a big thank you for doing so in a difficult situation, is Rachael Cummings, Humanitarian Director of Save the Children. Rachael is in Gaza, in Palestine, and prior to her current role, she was the Global Head of Humanitarian Health for Save the Children, and has many years experience working on Ebola in Sierra Leone, in Cox's Bazar, in Syria, and also in Ukraine. So a round of applause, please, for our panelists. So I think the first question we're going to start with is really want to understand the challenges and the problems that we face in conflict-affected settings. And I'll start with Rachael in Gaza with a slightly fragile internet connection. And Rachael, maybe you can give us an appraisal based on your current experience there of what are the most serious needs from a public health perspective in Gaza and in similar settings. Over to you, Rachael.
Thank you, George, and hi, everybody. Greetings from Gaza. As George said, I'm Rachael Cummings, and I'm currently the Director for Save the Children in Gaza with a background for quite a few years in humanitarian health and public health. Now, I'm hoping that some of the reflections of the situation in Gaza will also sort of trigger some thinking and considerations outside of Gaza. But, it's known and it's critical to understand the complexity of the operating environment for humanitarian health actors and for ministries of health working in Gaza alongside WHO. But just to give a sense of the complexity that we're working in and the crisis, which people will be familiar with, but we're now 13 months into this war and onslaught onto Palestinian civilians in Gaza. And, the UN just last week came out and said that Gaza is unfit for human survival, and I can attest to that. There's a population in Gaza of 2 million people, and around 1 million of those are children. 90% of the population have been displaced in the last 12, 13 months, many of them over 10 times now. They're losing count. Nearly 44,000 Palestinians have been killed, and 14,000 of those are children. And the number of injuries, although very, very difficult to count, is approximately 105,000 people with injuries. Now, if we consider the health system and how the health system in Gaza is able to respond to this war and the constant shocks it is experiencing, 17 out of 32 hospitals are partially functional across the whole of the Gaza Strip. Not one hospital is fully functioning, and that gives a bed capacity of around 1,500 for a population of 2 million. 10 emergency medical teams supported by the WHO Emergency Medical Teams Programme are operational, again, with partial functionality and providing an additional 600 beds. And of the 132 primary healthcare centres in Gaza, 57 of those are functional and only partially functional. Now, in terms of the impacts on public health, of course, we need to look outside of not only health, but looking at the social determinants. Water and sanitation has literally collapsed in Gaza. And so consequently, we see now the rise in diarrheal disease, the rise in communicable diseases, including with pneumonia and ARIs, with the extraordinary living conditions people are being forced into. And I think, again, what can be taken from Gaza and understood in other contexts is this compounding issue of public health complexity that we're trying to work within. So you have a mass population displacement, living in inadequate shelters. You have the breakdown of health services, including routine vaccinations. And of course, people will be aware of the first polio case that was detected in over 10 years in Gaza a couple of months ago, resulting in the need for a mass vaccination campaign in the middle of a very complex and highly dangerous war. So these compounding factors, including water and sanitation, resulting in very poor health outcomes. And of course, we have to also consider food and the supplies that are able to enter Gaza. People in Gaza are being starved. Children in Gaza are starving. And there is not adequate food to maintain any type of nutritional status for the population. So we're seeing increased rates of malnutrition. Save the Children, we're running health and nutrition clinics across Gaza, and we're seeing an increased rate of malnutrition, and worryingly, not only in children, but now we're seeing malnutrition in women and adult men. So that is extremely concerning, and again, a proxy indicator of the health status for the whole population. Another area that is deeply concerning, of course, is the attacks on healthcare in Gaza. And I was reading that there has been over 1,700 attacks on healthcare in Gaza, resulting in an extraordinary environment where you have people who are desperate to seek healthcare from a population prior to this war that had a very positive health-seeking behaviour. Vaccination rates were very, very high. But now communities and people see healthcare under attack. And so health-seeking behaviour has been altered. And we saw that very much during the polio campaign, where people were choosing not to visit the healthcare centres because they were impacted by direct attacks, even during the campaign, which was extraordinary. So I think, if the question is what can we learn from Gaza, I think we have to ask ourselves some very difficult questions in terms of what influence does WHO, the UN, and other humanitarian actors have in terms of influencing parties to the conflict? How do we hold parties to the conflict to account for attacks on civilians, civilian infrastructure, including healthcare facilities? how are we possible to even begin to prepare for such an extraordinary event that I think it's fair to say has been unprecedented in recent history? So we talk about health systems and being robust, but you have health workforce in Gaza that's directly impacted themselves, displaced multiple times. You have all of the supply chain routes, extraordinarily complex, trying to receive supplies into Gaza, facilitated by the UN, facilitated by WHO, and using commercial routes as well. But despite all of those efforts by many, many people, we're still unable to receive the goods and supplies that we need to. And then thinking around the health workforce, with the number of doctors, I don't have the data, but the number of doctors killed in this war, there's been significant efforts in terms of task shifting and sort of expanding the provision of healthcare outside of centralized healthcare facilities. So, how could we have, as a global health community, prepared healthcare workers in environments like Gaza to be better equipped, I guess, to be able to react to this massive attack on healthcare, which of course then has a direct impact on our ability to treat the populations in Gaza, which are now facing these compounding factors that are impacting their health, and of course mental health, and the crisis of mental health that we're now seeing, certainly in the immediate, but also trying to consider in the long term. The number of psychiatrists and psychologists in Gaza is woeful, but of course it was woeful also before the war. So trying to consider how now, in environments that are not under conflict, how can we build the mental health capacity to enable the healthcare system to be able to respond to the mental health crisis. Gaza was not equipped, and I'm wondering if Gaza could ever have been equipped for this complex and constant war. Thanks, George.
Thank you very much. Thank you very much, Rachel. And I'm going to turn, I think, next to Olivier, because we were just hearing about the challenges, and the question is asked how WHO can respond to a crisis of this scale, of this magnitude. And I think, Olivier, there's that question, but also more generally, how does WHO signal when a health system is transitioning into a full-scale emergency? Not even necessarily at the scale of what we're seeing in Gaza, but what are the mechanisms that WHO has to mobilize response to this kind of an emergency and predict and monitor once it's underway?
Okay, thanks so much. Can you hear me? Looks like this isn't working, but I hope. Is it not on? Can you hear me? No, it's not on. Is it? Okay, now it's working. Okay. Great, and thanks, Rachel, for outlining the. It's good to see you as well. Outlining the essentially the public health situation that is currently unfolding and has been unfolding in Gaza for 12 months now. I think, as you rightly said, Gaza probably, with the best preparedness in the world, would have never been prepared to the magnitude and the scale of the conflict and the destruction that is currently happening. And so, Gaza in some ways had a very good health system and a very functional health system before the crisis. So when we think about indicators, what indicates a crisis and an emergency that is coming, none of the indicators at the start of the crisis in Gaza would be in what we traditionally would see red indicators, in the sense that vaccination coverage was very high, access to health service was very high, there was a level of preparedness that was in place. But of course, no one expected what happened over the last 12 months. So I think it's just recognizing that at the level of destruction, suffering, and humanitarian need is by far greater than anything would have expected, certainly 12 months ago. Now, the question is about what are the indicators or the mechanism by which a humanitarian crisis is being sort of declared, or where you shift and you need to shift gears. So maybe going back to indicators, there's very poor indicators. In fact, there's no good answer to that. There's historic indicators of mortality. You may know those indicators of crude mortality rate of 1 per 10,000 per day, or under 5 mortality rates of 2 per 10,000 per day. But those were indicators that go back to crisis 20, 25 years ago when mortality rates were very high. And actually there were indicators that were more or less arbitrarily chosen, and they essentially indirectly capture the suffering and the morbidity, because it's an indicator that is mostly linked to indirect mortality. Going back to the point that OJ and Bhargavi made earlier, there's really a need to revise what indicators determine a shift to humanitarian crisis in the current context. If we look at Gaza, for example, with a well-functioning health system before the crisis, big burden of NCDs, a population distribution that is very different from those the crisis that we faced 20 years ago, mostly in African settings, those indicators no longer apply. It's the same even for other crises like Sudan. Sudan is probably in terms of numbers, by far right now the biggest humanitarian crisis we're facing. There's about 10 million people who are displaced in and out of Sudan. Healthcare access is extremely difficult. We've got attacks on healthcare in various parts. Vaccination coverage are very low. But if we look at the historical indicators and the sphere indicators, even in Sudan, they're no longer really applicable. So how the assessment is generally done is that there's a public health situation assessment that is being done at the start of a crisis and repeated regularly. And this is essentially a quantitative and qualitative assessment of what we think might be the biggest burden of disease coming up in the next weeks and months. They're generally done based on whatever available information there is in terms of your vaccination coverage, in terms of access to healthcare, in terms of functionality of healthcare before the crisis hits, in terms of the ability of organizations to operate, in terms of security, in terms of how many partners and international partners are already on the ground when the crisis hit. And that gives you a sense of how much can the crisis be responded to with the current means, or how much it needs to be scaled up. It's in its current design, it's very qualitative. We're trying to make the best use of the data we've got, but recognizing that actually in most places where there are large humanitarian crises, the data is of very poor quality. And again, it goes back to that earlier presentation today, where I think there's a lot of scope also for people here and academic institutions to support the design of those situational analysis and how we can be a bit smarter about doing them. Now, when there's a that is the sort of technical side of things. Now there's, in terms of actually moving into and shifting gears, internal to WHO, we've got a grading system that is actually not too different from the wider UN-wide scaling system from 1 to 3. So a grade 1, a grade 2, and a grade 3. A grade 1 for a crisis would be an assessment that the crisis can currently be managed with the current resources, the organization footprint on the ground, the partners that are currently operating. A grade 2 is a crisis that essentially is a crisis that needs a little bit more support, generally regional support, also in terms of funding, also in terms of supplies, supply chains, and all of that. And a grade 3 is all hands on deck. And that's all 3 levels of WHO in terms of the organization, but generally that then translate into a level 3, could translate into a level 3 crisis at the UN level. It means that all organizations will put maximum effort into supporting. That comes also with funding pledges, mobilizing donors to make sure that the needs are being met, and resource mobilization at wider scale. Then there's certain mechanisms that are being put in place for coordination, partner coordination through a cluster mechanism, for example, or sector mechanism. There's a cluster mechanism for health, there's a cluster mechanism for WASH, but Sean can speak to the health cluster in Gaza, and that's generally co-led by WHO and a partner organization to then make sure that we know that X, Y, and Z partners are doing this, this, and this. We know what the needs are, we know who is doing what, and that response can be coordinated. So I think with the volume of unpredictability we're facing right now in terms of crisis, there's one element of predictability, and that's the mechanism. So I think being clear about the mechanism of assessing needs, assessing the situation, but also the mechanism of coordination when a crisis hits, there's been a lot of improvement, not just in the aftermath of COVID, but also as a result of the improvements over the last few years in terms of really strengthening those coordination mechanisms when a crisis hit. at national level, at international level. So what is the sort of command and control, the chain of command when a crisis hit? Who are the best partners placed to do X, Y, and Z? And this is, a role where, WHO plays a role on the health side, but other organizations would play a role on the sort of WASH, on the nutrition, on the education side, and so on. Maybe I'll leave it to that, because that was a long question to a fairly short, long answer to a fairly short question, but I hope that answers some of it.
Thank you very much, Olivier. No, that was very informative. And I suppose maybe to you were speaking about Sudan. Obviously, we heard from Rachael about Gaza, but also today we mark the 1,001st day of the war in Ukraine, Oksana. And perhaps you could also speak. You're working closely with the Ministry of Health there on how the conflict has affected the public health system and where you see the greatest need for ongoing support in Ukraine.
Do you hear me like this? Oh, perfect. Works. Yeah, we have this agreement blood anniversary, 10,000 days, and we have statistics. Russia damaged medical facilities 1,657 partially, and more than 220 completely destroyed healthcare facilities. From this statistics, I would like to show you the complexity of damage to our healthcare system, because it's not only because we don't have working hospitals how it was before the war. It's also affected different systems. For example, when I used to speak with our Cancer Institute, they told that their system of servicing patients was completely ruined. They don't have feedbacks. They lost already communication between the patients and doctors. So it's difficult to help people from the east of Ukraine who was displaced. And as you know, 10 million people already displaced in Ukraine, and more than 7 million people left country. It's only partial things what I can tell about healthcare system. Also, when we speak with Ministry of Health, we understand that, as you know, they started their reforms before the war, and when the war started, these reforms were not completed. So it was complexity plus complexity. There is no specific budget what can cover all the issues, and also one of the biggest issue is expertise, experts and expertise. When I used to speak with, actually 2 years ago, it was Healthcare Forum in Imperial College of London, and we were speaking with Ministry of Health there, and we understood that they have lack of expertise in some areas. We invited our partners from UCL to academic group from UCL to help our Ministry of Health on their request, specific request, what they can help to work with. And probably we also need to remember that with these displaced Ukrainians, there are so many healthcare professionals left from the country, unfortunately. Here I have a community of 1,200 Ukrainian healthcare professionals. It's another story. It's a problematic of migrants and contributing to healthcare sector of Ukraine where they are now. Some countries managed to contribute into their healthcare sectors. In the UK, we still have less flexibility with our healthcare qualification. And yeah, probably it's what I can tell for now.
Thank you, Oksana. Sean, we've heard a little bit about the changing nature of conflict, the additional complexities from Bhargavi this morning about climate change as a factor, amongst other things, and of course the highest number of violent conflicts around the world since World War II, according to the Security Council. And we've heard a bit about how, for example, WHO structures exist, but also how conflicts in Gaza, Sudan, Ukraine are quickly overwhelmed by contemporary conflicts. Based on your experience at the hub, where do you see the opportunities for innovation to address some of the structural failings and gaps in the way that we are currently geared up for delivering healthcare in the middle of a conflict?
Hi, good morning, everyone. I think that's working, is it? Yeah. Thanks so much for inviting me today, and to my co-panelists for setting the scene so well, both in terms of specific contexts and more generally in terms of the approach of WHO and others. Maybe I can start by just outlining the perspective that I come to this topic from. So I work for the UK Humanitarian Innovation Hub, which is a pilot initiative hosted at ELRA. And I'm also joined today by Claudia Wynne over there, who's representing ELRA. A lot of our work focuses on how research and innovation can support both the humanitarian system and the way that humanitarian system interlinks with core health systems to ultimately save lives and alleviate suffering in these moments of crises. I think what we have seen over the trajectory of work on research and innovation is that we initially focused a lot on specific interventions and research related to those, or specific innovations and supporting those. But increasingly, we realized that we would fail to create any kind of transformational change unless we actually thought more structurally about how these things can interlink and intersect within that broader system. Within the hub specifically, we recognize also that we can't just be talking about systems change in a really vague or inarticulate way. Instead, what we actually need to try and build is specific mechanisms through which we can allow our partners, academic innovators, researchers, humanitarians, affected populations, to actually understand and identify levers of change within humanitarian and health systems. And so in terms of my perspectives, what I'll try to share in relation to your question, George, is what I see kind of filtering up from the work that the UK HIH and ELRA do. And underlying that are perhaps two assumptions. The first is that humanitarian action is always intended to step in when existing state health systems are not strong enough to cope with a particular crisis. So in an ideal world, they should always be temporary. But I think the reality is that the way that we behave as humanitarians often has a lasting impression. So we have a window of opportunity in a moment of crisis to act in a way that can either strengthen or weaken a system. And so I think that is the question that we always need to be considering. Secondly, like we heard a lot this morning about the COVID-19 pandemic. We hear from Rachael and Oksana about the very unique, and also Stan, the very unique crises we're facing in the world at the moment. I think it's important to recognize what is novel about a crisis. Perhaps that's the scale, perhaps it's the way that it exacerbates vulnerabilities or affects a population. But it's very rare that we can actually say that a crisis is fully unprecedented. And there's clearly a lot of work that we can do to make sure we are building on learning and facilitating peer-to-peer sort of connections and sharing in terms of how we actually then build systems. And I think in terms of what has been filtering up from some of our work, I think I have two main reflections. So firstly, I think that we are still treating populations as separate to health systems instead of being at the heart of what health systems are designed for. We tend to just tokenistically kind of engage people at the point of delivery of services and then wonder why they don't have the kind of trust that our speakers described earlier on this morning. And we still treat them as being fairly passive, and yet we recognize that in moments of crises, populations are the first to be providing mutual aid to others. They are the frontline humanitarians, that when we talk about task shifting, for example, as Rachael said, we often see that passed down not just through different levels of health workers, but to populations themselves. And so I think there's a real opportunity to shift gears on the way that we actually meaningfully consult communities and bring them into the way that we deliver healthcare. Secondly, I think most of the systems that we use as the humanitarian sector to scale up and surge health support in crises are still rooted in very colonial architecture. And despite a lot of goodwill to try and change this, it's proving pretty hard to change because the incentives just aren't there. And so there's still a real tendency to fly in experts from high-income countries for short stints in acute crisis environments where the technologies, the skills and the capacities that those individuals have are simply not relevant and are creating damage. And yet, in contexts like Gaza, like we've been just doing some work on humanitarian surgery, we have an incredibly skilled workforce where many chose to stay in absolutely incomprehensible conditions, where those surgeons have been that are based on the statistics we have, clearly being targeted. I can speak to our own experience. We had a junior plastic surgeon in Gaza who was killed in Al-Shifa Hospital earlier this year doing some of the research that we were funding. These kind of individuals had the capacities to support the health system there, and yet we are flying in sort of temporary assistance. We're not necessarily making the connections that we should. So we also have done some research to learn about the informal ways that surgeons are coping. So for example, there's a WhatsApp network that's connecting Gazan surgeons to Syrian surgeons, and they're exchanging notes on how to innovate in surgical care in the most dire of conditions. So the Syrians are saying, this is how you keep a generator running when there's no fuel, and this is how you perform this operation when you have no anesthetic, and those kinds of extreme frugal innovation where peer-to-peer networks can be so vital. And I think really what we see in the current mechanisms of surging support is a silencing of local voices and capacities. And that, until we rectify that problem and until we really think about different mechanisms for doing that, I think there's a real risk that we will continue to perpetuate as humanitarians, and also as perhaps the academics and those who support that humanitarian architecture, that we won't see that long-lasting systems change.
Thank you, Sian. Marine, we've heard a little bit about innovation in broad terms, research for innovation, and some of the frugal innovations that are emerging in conflict settings. Alima pilots technological innovations in under-resourced or low-resource settings. And perhaps you could describe for us a little bit the practical challenges in terms of last-mile delivery of technological innovations in very complex settings, including conflict.
Thank you. I don't know if it works. Yeah, it's okay. First of all, I just would like maybe to introduce quickly Alima, because I don't know if everybody knows the NGO. So Alima is a humanitarian medical NGO, and we work with local players, and our model is based on a partnership with MOH and, in some countries, national NGOs. And this morning, Elena showed a map with a red part, and Alima work only on the red part. So we're health system with major challenges, I think. So we are present in East Africa, East, Central Africa, and also in Haiti. The NGO was created by staff from MSF, and we have a very close relationship. In 5 countries in West Africa, we work with national NGOs. And the specificity, I don't know if I can say that, is that Alima has built an expertise on responding to epidemics such as cholera, measles, COVID-19, the different waves of Ebola, and more recently on Mpox. And the particularity is that we work on the medical response and operational research together. And maybe it's the most challenging, if it was the first question about the challenge, is how we can respond properly to the emergency and in the same time drive operational research, and in the same time bring the community and bring awareness to the community, because it's essential. And the example we have is Ebola, and a lot of lessons learned from Ebola management. About the research and innovation, it's a very long process, and we cannot just take a new tool, diagnostic tool or new thing, just introduce it and scaling up. That's completely impossible. So our view is that we have to mix qualitative study, quantitative results to have like scientific evidence, but also to be sure the innovation will be acceptable by the population. But what we need to scaling up an innovation, a cost effectiveness study, because the cost is so important for government to know if it's feasible or not. And how we work at Alima is we bring in the country also a national advisory group with a mix of people, and with government, Ministry of Health, if it's Ministry of Health, and pediatrician, and also civil society, to have everybody, and we bring them since the beginning of the project, not at the end when we have scientific evidence, because we know that's the very specific relation we have between researcher and humanitarian. We don't have the same timeline, and we have to work together, but also with Ministry of Health to leverage the results, but also to change the results into national operational action, how we will implement it, and also in political decision. About it, maybe I can stop here.
No. We'll come back, and we'll have another round of questions, but then everybody start making notes, because I'll be turning to the audience soon for questions from the audience. But before that, I wanted to go back to Rachael in Gaza and ask. We've heard about some quite practical examples of innovations that have emerged in the more recent phases of these various conflicts, and I wondered what you're seeing, Rachael, if you're able to share any examples of very practical changes to the way that Save the Children and other actors on the ground are adapting to the necessities imposed by the nature of the conflict in Gaza.
Thank you, George. And yeah, good question. Very challenging. I think, Save the Children, along with other humanitarian actors, work, and I take the point from the colleague from the Innovation Hub, in terms of disrupting civil society. We're very conscious of that. We've been working here for decades, so our approach is very much hybrid in terms of working with partners and providing direct services to not disrupt existing civil society. However, civil society itself is massively affected and overwhelmed. But I think, it sounds a bit trite, but, the resilience and the adaptability and agility of the people in Gaza is really what I'm seeing and what I'm witnessing. And how do we foster that and support that? So, things sound very small. I like the example given about the WhatsApp groups and sharing information between Syria and the clinicians in Gaza. I may be on around 100 WhatsApp groups in Gaza, and this is how people are communicating, because however damaged the infrastructure is around telecommunications, sometimes data pops up and people are able to use WhatsApp as a really extraordinary tool, actually, to share all types of information across different groups. So I think, the use of telecommunications in a very different way. I think also the use of local resources. Now, local resources are extraordinarily depleted. The markets are depleted and restricted. However, again, the agility of people from Gaza, who obviously know the context so much better than people like me, and their ability to find local solutions to some of the challenges. And I'm talking really basic things like tents for provision of learning for children or child-friendly spaces. Now, the tents are not allowed to come in to Gaza. So what solutions can we find locally to provide some type of shelter for children in a child-friendly space, as a very, very small example. But I think, I think also one of the things that maybe is what I'm seeing, I guess, is the collaboration with the EMTs that have come in, the emergency medical teams that have come in with often very niche and specialized skill sets, working alongside agencies like MSF, like UK Med, who are running field hospitals, and then this collaborative approach with the Ministry of Health and with UNRWA, of course, who are a massive provider of healthcare services. Gaza has a complex healthcare system, as everywhere does. There is not a homogenous healthcare system in the world, but this collaborative approach, and often trying to find very, very local solutions and moving people around. Again, this sort of skill shifting and task shifting, which I don't think was in place before this war, but the war has necessitated that type of agility, which is not easy. But I think we're being forced into these spaces to really drive us to find these very localized solutions, because the solutions are not coming from outside Gaza.
Thank you, Rachel. Oksana, maybe a sort of similar question to you in the Ukraine context. Ukrainian medical charity, which you lead, amongst other responsibilities, supplies critical medical supplies to the front line, to healthcare facilities and clinicians. What are some of the challenges that you face in that last mile delivery, and what are some of the adaptations that you've seen emerge in response to those challenges?
Thank you for the question, and it was really great to hear everything what you tell, because I understand that we are partially in everywhere in all of our activities. So we have requests from Gaza healthcare professionals about our experience in mental health, how we managed to support for millions of affected by the war children, and we also I was also believe in defining specific role of small organizations which makes impact on the place, on the ground. I would like to add some information about Ukrainian medical charity, what I missed from the start. So we have 4 focuses: empowering Ukrainian clinicians to find opportunities in the UK. As I told, we have a big community here, and we want to help to contribute their qualification to the UK healthcare sector, as well as to keep their professionalism when they come back to Ukraine, to learn something new and to come back with knowledges. We are establishing platform for exchanging huge knowledge what Ukrainian healthcare professionals daily gaining on the front line. Small example, I had from the beginning of the full-scale war, I had so many requests from UK professionals to help, how they can to help, and it was meeting between burn specialists from the UK and our burn specialists from Ukraine. And when they met, and our Department of Burn told about the request, about 60% of body burn, about 3 days being in the mud. So how to help these people, how to help these wounded people, and it was obviously became that only specific expertise from experienced people in combat or in other similar disaster can be helpful in this case. So my goal is to establish this platform not only to channel expertise from the UK, which is very important, but also to share our experience from our healthcare professionals from Ukraine. We also have mental health, rehabilitation, and educational initiatives. And as I told, we have researches for mental health. For example, we have research of 4,500 children in Chernobyl. It's on the west of Ukraine. It's kind of not so dangerous area in Ukraine like everyone thinking. And it showed that 40% of children were affected and have PTSD. Can we imagine what we can see with other children or other adults? And obviously, delivering critical medical supplies to healthcare facilities in Ukraine, acting as a channel between UK or other countries to Ukraine, it's one of our main focuses. From the first days of full-scale war, we were able to set up and supply 7 hospitals over a year with a medium-sized donor dedicating 4.2 million as equipment and consumables. As a small organization, we had advantage of flexibility and quick reaction from the first days. So our first truck went to Ukraine at the beginning of March. We all remember that full-scale war started on 24th of February. And less than a month, we already sent this. Also, when for example, Kherson was deliberated on 11th of November 2 years ago, we were one of the first who also helped immediately, like in a few days, to help them after the occupation. And obviously, big organizations had to manage with bigger time to deliver this. After a year, probably, of supplying these 7 hospitals with medical supplies, we understood that big organization already started heavily supporting regional hospitals. And we shifted our focus to small medical teams and hospitals next to the front line where big organizations probably cannot deliver such easy these supplies. We have a chain of our contacts who works with stabilization points, so we have always requests from them. We have medical teams on the front line in brigades who cover different quantity. They are always moving, so we have requests all the time. And about the issues. When I still was in Ukraine in February 2022, I was, as a volunteer, helping to supply needed consumables to places where it's needed, where it was bombed and lots of people were wounded. And the biggest issue was not even people or medical supplies, but the logistical expenses. We have the same because we work with trusts, NHS trusts, who supplies us monthly with their stocks, or some donors who wants to support specific medical equipment when we request. But still, we need to send this to Ukraine, and it's probably for us as a small NGO is the biggest challenge. Also, I would like to mention that our organization is volunteer-based organization, and all my volunteers are mostly women with children who came here 2.5 years ago as well as me, and trying to find their place here to work. And yeah, volunteers and logistics probably is the biggest issue, because we have people who want to spread their medical supplies, our medical supplies on the ground daily.
Thank you, Oksana. And you mentioned in describing the work of the charity that it's partly about bridging between Ukrainian medical and health workers and British counterparts here. And I think that reminded me of what OJ was saying about the work of J.I. Rice and trying to find this bridge between academia on the one hand and humanitarian context on the other. or to strengthen that bridge. And Sean, I wondered if that's something that you could pick up on in terms of, your experiences through the hub of trying to understand better the role that academics can and should play in supporting local health systems in humanitarian emergencies, including conflicts.
Yeah, sure, and I agree that component of JIRISE's ambition is going to be really critical and really exciting, I think. So, I mean, I think my advice to any academic sitting here in the UK is both to be aware of your skills and the power that you hold in the institutions you work within here, and use that carefully and effectively in these types of settings. Clearly, any kind of academic collaboration needs to be through a kind of partnership approach. Clearly, it also needs to be driven by problems facing those closer to the front line. And I still think we're not great at doing that. Sometimes when I see funding opportunities available, I mean, and I've been in this position myself as a prior academic, often we have a research ambition, we try and twist it to whatever the kind of funder is sort of looking for. And ultimately what that means, I think, is that we end up funding priorities that are already in the heads of high-income based academics. And I think we really need to build stronger processes for surfacing problems from frontline actors and community members, and then kind of building out an understanding of what those problems are and therefore what the research approaches are that are needed, rather than starting from just the skills that we have. And I think the other thing that's been really clear to me through some of the work that the Hub has done more recently, where we've actually mapped some of the UK expertise in the humanitarian sector and on humanitarian topics, is that if you're, again, a humanitarian staff member with an immediate pressing problem, you don't always necessarily want a big innovation or research grant. Sometimes what you need is just a quick summary of the evidence or some practical guidance in terms of how to translate evidence and innovation into practice. And I think what that actually requires, and this is where it links, I think, to the ambitions of JRIs, is that I think we need to be more creative about the way that we can actually form partnerships between different types of actors in the sector, because the issues are complex, but we do have a world worth of expertise. And I don't think that many of the problems that we are dealing with are so complex that we couldn't address them more meaningfully by working together. But I do think we need to see that the model of academia in the UK, for example, and the way that the humanitarian system works, they're kind of miles apart in terms of the ways in which individuals within those organizations can work together. And so I think there is something to look at, perhaps what could be seen as the side of kind of unsexy side of collaboration. How can we provide mechanisms of funding and knowledge sharing? How can we be more exciting about the way that we contract, that we provide grants, that we support expertise sharing? That kind of thing, I think, is really ripe for innovation.
Thank you, Sean. I think we'll close with WHO, but before, I wanted to ask Marine, we're just hearing from Oksana there a little bit about the challenge, the logistics challenges of delivering frontline supplies, but also from Rachael in Gaza with some of the tangible and kind of frugal adaptations. And I wondered whether, earlier, Marine, you were sort of explaining some of the challenges that are faced, but what are some of the sort of more positive successes that you see in terms of the adoption of technological innovations in public health systems under strain?
When you speak about challenges, I think about the COVID-19 pandemics, and it was a kind of mess. And the global tension just to have oxygen was completely, it was so difficult. We joined effort with MSF to try to find 5 concentrators for one country. And the situation was that in Central Republic Africa, they have 5, I don't know the name in English, but reanimation bed, like intensive care beds, and 1 reanimator doctor for the full country. So I don't know if you can imagine the difference between this kind of country, and they have nothing. And it was like, my job was to manage a global project to drive a pilot innovation in 5 countries to diagnose respiratory disease. So the perfect time to have other funding to work more on oxygen. And with the team, we work with the Mali governments and Guinea governments on this introduction of pulse oximeter in the national health system, and we came with like a lot of protection for doctors and then oxygen. And everybody were around the same table say, okay, we need to try to find something. And the problem is that we were able to diagnose the respiratory, like the hypoxemia, but oxygen was not available. So we call our favorite researcher. The researchers were able to write a research protocol in 2 weeks to have like evidence. And we work with the donor, it was United, and say, okay, we have an idea and we think we should try to decentralize the access to oxygen. Because the problem is that in main city, it's okay, they have oxygen. But in a rural area, we can diagnose the hypoxemia, but they don't have enough oxygen at the like secondary hospital level. And what we did is that with a small team of innovation, researcher, humanitarian, MOH, we built a small team, and we did this trial in 1 year with preliminary results very fast on acceptability and to know how to introduce very fast an innovation in an emergency situation. And the goal was to give oxygen to the patient during the transport with solar power and everything. And we did it with like quite good results. So I think it's a small good news.
Thank you very much. And before opening up to the audience, Olivier, kind of the perspective from WHO, I mean, what are you seeing in terms of advancements and progress in how WHO is able to anticipate some of the worst crises and therefore mobilize responses effectively? But I've also been struck by a lot of what other panelists have been saying have been quite small, not small scale, but sort of micro level collaborations, whether it's between researchers, whether it's between organizations. It's rapid, it's on the hoof, it's frugal. How is WHO thinking about trying to support that kind of response beyond the sort of more conventional, big scale, macro WHO intervention?
Okay. There's a lot to unpack in your question. So let me try in terms of anticipating. I think that goes back to essentially surveillance systems and innovations in surveillance systems. And I think there's a lot that can be said about innovations and how they translate actually in practice and how they sustain. And I think that goes back to your point, Sean, as well, about essentially making sure that countries can be prepared and settings can be prepared through use of potential modern technologies or not. And I can speak of experience in many crises where the needs of the crisis make that there's technology being introduced to, for example, pick up epidemics quicker, early warning systems, tools that many of you know, perhaps HIS2, Go Data, Survey 123, ODK, all of that. With no mechanism to then sustain that support when the crisis is gone. And I can speak from, having spent many months or years in North Kivu in DRC on Ebola outbreaks, for example, where we had, I think, an introduction of about 4 or 5 different digital tools at once. And those are pushed generally not by an assessment of the situation and what would be best, but generally by funding and partners and who does what and what is most useful for a certain person. And then you come back and essentially there's a fragmentation of a surveillance system in a country, linked in part to partners responding and supporting through surge an emergency or an epidemic response. That's acutely sort of visible in DRC, and I'm just back from Kinshasa in the context of the Mpox response, where you see real fragmentation of the epidemic early warning tools in the country. And I think WHO plays a role in that fragmentation, in the fact that some tools have been pushed by one organization, some have by another organization, with no plan to really sustain it. And that's something that I think is a challenge, something that needs to be addressed. And in fact, when you see what the needs are, it's generally not the tool that is needed. It's the structure and the human capacity on the ground, payment of staff who are doing surveillance, ensuring that there's on the ground capacity that is being sustained, no matter what tools is being used. Right now, a tool of surveillance that would work well is a tool where you've got any early warning of something suspicious that is being referred to the central level, and that people can analyze that, no matter what tool is being used. So I think sometimes we need to go back to basics and say, well, through a surge mechanism, through a humanitarian emergency, or to an epidemic that in itself could be a humanitarian emergency as well, what can we do to make sure that we leverage that emergency response to then better prepare for the future? And I think we're still missing on that front because of the magnitude of the surge, sometimes needed in places, sometimes not needed in places. To your point, I think there's other ways to surge capacity as well than having a model of mostly high-income countries surging in. And that is being also, currently, I think there's much more start-to-start support in Africa, for example, as well. The Africa Health Volunteers, AVOC system, which works, it's in its infancy, but works pretty well. And WHO is trying to coordinate that as well to make sure that there's more like neighboring countries supporting each other, and that increased sustainability. So that's maybe one thing in terms of the capacity to predict. I think is also conditioned to some extent, not just on the tools, but on the capacity to make sure that there's essentially a health system that is being strengthened through responses. I'm seeing it through the response lens because that's mostly the work I'm doing, and I think it's an opportunity response to strengthen the health system. Now, when it comes to a humanitarian emergency linked to conflict, and I can go back to the situation of Sudan, for example, the issue is that then you could have a system that will, at the national level was well functional before, but will no longer be functional, and something else needs to be put in place because you've got new actors, you've got inaccessible areas, you've got a country that might be fragmented on a historically government side and a new side. So that's the situation in Sudan right now, and there you need to be able to use some of those innovative tools to have, in the context of surveillance, for example, an early warning capacity. And that's being done by tools that are being rolled out right now with WHO coordinating with local partners, how you can scale up an early warning alert and response function with new partners, local partners, working through, for example, the medical unions and others to be able to work with local doctors to do that. Your question was very long, and I don't have notes, so I can't.
You've covered it. You've covered it, I think, and I think that the message of back to basics is also quite an important one, and I think covers this this point I was raising about how on the ground at the sort of micro level WHO is best prepared to respond.
Let me just go to one point on the macro level again. I remember what I wanted to say here. There are surveillance innovations that have worked really well, and I can take the GeneXpert example of DRC. GeneXpert was introduced in DRC for rapid testing of tuberculosis initially through the TB program, through decentralizing the sort of capacity to diagnose tuberculosis given the high burden in DRC. That was then leveraged to be able to diagnose Ebola at a much more local level. Currently, Mpox at a much more local level. So I think that's an example of something that is sustained because it has the commitment, it has some of the funding, and the perceived sort of utilities is great. The other thing at the macro level that I can speak of in terms of predicting and surveillance is the whole work around AI-driven tools, media scanning, for example, to trying to identify a problem when it comes. It's our bread and butter right now at WHO when it comes to try to pick up signals before they're being reported to us. The extent to which it does the job, I'm not sure. And I think it should be actually looked at. And how are epidemics being picked up? Are they picked up through media reporting and scanning? Are they reported through IHR notification? It'd be useful if someone has time to actually look at that. But mostly, it doesn't really work in settings when you don't have media reports and social media. It doesn't really work in the actually hardest to access humanitarian crisis. And so those tools are great for many places, but they're not tailored to the needs of those areas where essentially information will come from local network, from working with Red Cross volunteers, from working with doctor unions, and from working with people on the ground like that.
Fantastic. Great note to close the official questions round. But now let's go to the audience. We have about 10 minutes left before lunch. Sarah has the roving mic. Can we take maybe 2 or 3 questions to begin with and then pull them together? Thank you.
Panel, great discussion, and it's kind of nice to hear the conflict zone, how complicated situations are, and how the WHO is responding, and also how technology and innovation can actually fit into helping with the situation. So I have a kind of a macro level question. So I'm actually visiting from the US, and so everybody knows that there's going to be a change of government, and we just appointed a well-known anti-vaxxer to be our health minister. So strengthening healthcare, strengthening health system, very resource heavy, depends on funding. Going into 2025 for the next 4 years, there's almost guarantee that funding for research, education, public health, everything will be cut. So I'm just wondering whether UK, EU, or WHO, how not to be self-centered, but when something like that happens in the US, it kind of trickles down to the rest of the world. So how do different organizations, government respond, or how are you planning?
Take a couple more.
Well, first of all, I wanted to thank you for all the presentations, and I wanted to thank Rachael for sharing her experiences. I think very inspirational and a lot of food for thought. My question is more related to the talk I gave today on breaking the silos. I know I was a bit scared about asking this question, but I think I'm going to go ahead. So I'm quite new to working in health and humanitarian settings. My background has been more on migration, health, refugees, and displaced populations, and I'm aware that this topic has not come up today in our discussions. And my question is around that. I'm starting to kind of communicate more with expertise on humanitarian settings, and I see a complete disconnect. It feels like a humanitarian we focus on the countries, and then we don't pay too much attention on what happens with displaced populations or thinking about the future. And then we do the same. Like when I do my research, I start with once they leave the country, what happens to this person? Then they move, then they have this. Happens in the academic world, we are completely separated. We don't even talk to each other. I've also experienced it happens in international organizations, and I think if I can say, I think it even happens within WHO. I've been trying to communicate with the groups, and you're all in separate places. So any reflection on that? Because at the end of the day, we do need a systems approach, and people suffering, they go through all these stages that we are seeming to put a barrier there in our work. So any advice on that? And sorry if the question is a bit controversial.
Do you have any? Over here.
Hi, thank you so much. My name's Aldine. I'm a research fellow here at Imperial. This has been really fascinating. I think one thing that struck me about the sessions in the morning as well as during the panel is that a lot of the discussions sort of use crisis or like humanitarian setting as like a catch-all term, which can mean epidemic or pandemic or outbreak or conflict or armed conflict or environmental crisis or whatever it may be. I guess I would be curious about what are the similarities and differences that you find. And I think I'm coming from this from having done a fair amount of injury prevention work very recently, thinking about conflict-related injury. And I think it's apparent to me that the data systems are worse. There's less funding, there's less interest, it's way more political. Like there are all of these issues, and I just wonder how, what are the similarities and differences that you think can be applied to conflict settings from other types of crises? Yeah, thank you.
Thank you very much. Okay, we're in rapid fire mode now as we get to the end of the session. So we've got 3 questions. One about the change of administration in the US, one about breaking down silos, particularly between displacement and conflict, but more generally as well, and one around conflict and other crises and what can be the learnings across the two. Rachael, maybe I start with you. Would you like to respond to any or all of those?
Thanks so much. I don't think I'll respond to the question on the US and the trickle-down effect in Gaza. Deeply concerned about the new administration and what that means. I think in terms of learning maybe from conflict, and again, learning from Gaza with this compounding challenges, I guess, that people are facing here, not only with the conflict, but the mass displacement, the lack of protection, the lack of environmental sort of protection from the environment, rather, and the social determinants impacting on health outcomes. None of that is new, I think, but I think one of the areas in Gaza that is extremely sort of exacerbating is the limited space that people, physical space that people have. So, you know, all of these compounding efforts also in a very, very short time. I don't know if that's any learning from other environments, but I think, you know, if we're talking about resilient health systems and trying to build resilient health systems, I think, you know, health systems require investment, and under conflict, we see that there is multiple challenges on the health systems and the populations that those health systems are here to serve. So I don't, again, no answers to any of this, but I think it's a good challenge. Thanks.
Thank you, Rachel. In-person panelists, anybody like to respond? Olivier, I feel like you were somewhat called out there. Maybe we'll start with you.
Right, I'm not going to respond in detail on the question about the US change of government, but just to say that the many UN organizations and international organizations depend on funding from the US, including WHO quite heavily. None of the strategic response plans for humanitarian emergencies and indeed other emergencies right now are fully met in terms of their funding. There's a funding shortfall across the board. So if that funding shortfall becomes even bigger, I think we down to some more difficult crisis to respond to moving forward. So I think, you know, without wanting to go much more in detail, I think it's a worry. It's a worry, and I think it's a worry not just WHO, it's a worry in general globally in terms of our capacity to respond. On the question of silos, I'd love if you could break some silos within WHO. That'd be great. Maybe we can connect about how to do that. So we can work on that. But to your question of migrant health, actually, there are links between the migrant health. If you refer specifically to WHO, which is outside of the emergencies program, and the emergencies program when it comes to IDP, refugees, and migrants. A good example is actually the crisis in Ukraine, where you had a lot of migrants into Eastern Europe and Western Europe to some extent. WHO didn't really have, and many other partners didn't really have experience in working in those countries, and the countries themselves were thinking, do we need support? How do we deal with migrants and refugees? Sometimes it was just about signposting, make sure that health services were available, make sure that structures and facilities were there to sort of welcome people. But the link with the migrant unit there was quite important, and I think it happens in some other conflicts as well. And then the question around the difference between humanitarian conflict versus epidemic versus all that. So I think when it comes to the response to it and the mechanisms of response, they're not too dissimilar. In fact, what you need, you know, in some ways, a coordination structure in place that is efficient, that works. There's a coordination between partners. There's a coordination within or between government entities when you need to. And so having that in advance of a crisis hitting is of course important, and we know that's part of the preparedness, but it's not always the case. And so really being able to map out who does what before a crisis is important. In the context of humanitarian, it's sometimes different depending whether, you know, types of crisis in the conflict. Generally the government might be a party to the conflict, so you've got slightly different coordination mechanisms, but the principles of it are fairly similar. What changes is the sort of technical input you need for all of those. If it's a specific epidemic, of course, you need to leverage that specific expertise. If it's a wider humanitarian crisis, generally it's about ensuring that the basic needs of the population are being met and a prioritization within. And then the difference as well in some parts is issues of access and security. So if you are in a humanitarian emergency where the access to a place is very difficult, where there's security concerns for staff, not only will you want to make sure, or in many cases you may not have the same bandwidth in terms of staffing, the headcount might be more limited, but also in terms of how you deliver interventions might be quite different, because you don't have a delivery of interventions through health facilities as you would normally do. You may have snapshots, you have for example, take the Darfur example right now, the access is very difficult, so you go in and you deliver whatever you can in a short space of time and you come back. Question of vaccination, we heard about GI rise this morning, so vaccination in a setting like this, clearly there's no API vaccination, it would be, come back in 3 months if you can in hard to reach areas, so what vaccines do you give to protect the population over that space of time? So the questions and the mode of delivery might be different, but the principles of coordination, of funding, of accountability and all of that roughly are the same, and that's the whole effort in trying to strengthen that emergency coordination preparedness in countries.
Thank you, Olivier. A last word, anybody else? Marine?
I just would like to complete the before and after emergency response. And the key is also the emergency preparation, the preparedness, and work together, of course, and after the emergency response, what's happened after. And we think that effort must be not relaxed at the end of an epidemic, because there is, like for cholera, for example, we know that it's a recurrent disease and we have an immediate response. And I don't know if it's a good word in English, but it's a sawtooth response, like we just reply quickly and we don't think about like, hey, next year, maybe we will have the same at the same time. And we know that. And so maybe epidemics should also teach us lesson learned and to question the health system, surveillance, and reinforce them on ongoing basis to put in place multi-risk and multi-epidemics contingency plans after the response.
Thank you. Sean, a word?
Yeah, I can maybe briefly add 2 comments on the America question and the siloing point. So I think, the situation in America is as it is, but I think at least at a personal level, the question that I've found myself asking is, well, what led to this point? And actually, I think it's the big picture version of the things that we grapple with at a micro level when we're doing particularly pandemic or outbreak response. It's that mistrust, it's that perhaps disillusionment with the services that people have received from health systems. And so particularly as people involved in the generation of evidence, I think that needs to continue, but we have to be mindful of how evidence is no longer sufficient. We need to understand the way that people around the world, including in the US, are constructing disease and health. And we must make sure that we are not just pushing out information, but we're really taking time to translate that information into narratives that can speak to them. And I think, it's very easy to just be very critical of the current situation in the US, but it's also a challenge for us to work differently and to work better on some of the dissemination and engagement around our work. On the second point from Helena, I absolutely agree. I've noticed that gap myself, particularly when we did that piece around mapping UK expertise. These were communities that just didn't speak to each other. And I think what has possibly happened is that given the complexity of the types of crises that we're trying to respond to, our approach as the humanitarian sector and as academics has been to try and pick off a chunk and coordinate within that chunk. We've done that in the sort of silos that you described, but despite the amazing progress that has been made with the cluster system, for example, our tendency now is to coordinate with all of the WASH actors, for example, about WASH needs. And we forget that a person's sanitation and hygiene practices and their resources are inextricably linked to their livelihoods or their health. Like for a person who's experienced a crisis, those silos make literally no sense at all. And so it is a challenge to us, like to come back to that core humanitarian principle of humanity and make sure at the end of the day we understand first and foremost what people are experiencing and try to ground our work in that, and still to promote all of those efforts in coordination.
Thank you. A final word, Oksana?
I would like to slightly touch with my answer first and second question. Due to our experience and my understanding how we might change or how we can improve resilience of healthcare sector with our efforts. And I would like to mention that we have different participants in this situation, like government structure, big organizations, small organizations. Everyone has different capacities or different flexibilities. And as I told, for me, from my perspective, defining the role of small organizations with their key local network gives strength in the future, resilience or immediate response, emergency response in any situation. And I would like to mention that as smaller as micro level it is, it less probably sometimes depends on bigger changes, because while this bureaucracy machine coming to the this level, still there are so many local teams which will make work on the ground. It's my point of view. And about sorry, sometimes my English. So about people who left their country because of the war, it's also relies on networking of partnership, which is really matters during each situation, each disaster or war. For example, we have as an answer of mental health problem with affected children in Poland. We have project of calls Solve with WHO, about 26 minutes translated to Ukrainian digital intervention, which helps children right now already find their stability. And yeah, probably.
Thank you, Oksana. Well, I've failed in my primary objective, which was keeping us to time, for apologies. But it was a fantastic discussion, and a round of applause, please, for all of our panelists, including Rachael in Gaza.